some of you may not know me, and my name is Frannie Koe. I'm a family physician in Collinsville, which is about an hour and a half from here. So I'm like exactly halfway between Birmingham and Chattanooga, and an hour and 15 and an hour and 15. So it's a really small town. It's about 900 people. And I was surprised that Darryl had asked me to come do talks at his herb conference because I'm not an herbalist. He knows me, and he knows that I'm willing to use herbs, and that's what I do. So I don't use very many, but I've been going to herb conferences for about 5 or 6 years now and trying to learn as much as I can so that I have more tools. Because, so in a family, for a lot of physicians, we only have so many tools, which are drugs. And we do have education, but a lot of doctors don't have time to teach. So I spend a half hour with every patient, no matter what. We don't even schedule people less than that in my regular insurance clinic. And I learned how to do that through coding and billing years ago. Now I have a direct primary care clinic, and I can spend an hour with a patient. And so the thing about direct primary care is a lot of people don't have insurance. And so I've got to find other things that are less costly than really expensive medications to help them with different items. So my talks are on sleep and dementia while I'm here, and sleep has been a big issue for some of my folks, and I have really struggled helping my own partner and then some of my patients with sleep. So today our talk is on sleep, and so I asked some questions of you guys. Who here has trouble with sleep?
I don't anymore, but it's been the journey of my last 5 years to figure it out.
Wow.
Yeah.
So I may ask you some questions as to how you made it through and how you're not having trouble. Because my own partner's had trouble since he was a kid. But some people have issues like PTSD, and their mind goes, and they can't stop thinking about things and all kinds of stuff. So we'll talk about all that. And are there any herbalists or practitioners in this group that actually treat patients? No. Okay. You may treat your friends, but you don't have a practice per se. Okay, all right. So I'm going to start with. I'm trying to break this into sections so that when I do these videos, I can do little short ones. So we may stop, ask a couple of questions, and then move to the next topic. So I have all these numbered. And I have to talk kind of fast. I hate to, but I have a lot of information, so I'm trying to. So I'm sorry, but I will give you time to do questions. So what does sleep deprivation actually do to us? So some people may know that because if they haven't been to sleep. So I was a resident in residency, and we had to work 120 hours a week, and they didn't change the hour. They changed the hours down to 80 my last year. So, and I was already out of the have to stay up all night, as a medical student and as a resident. I was actually a white cloud, they called it, because somebody upstairs somewhere knew I needed sleep because I do not function well without sleep. So, so there were black clouds, the ones who had to stay up all night all the time, and I rarely ever, maybe 3 to 5 times the whole time I was a student and a resident, did I have to stay up all night with no sleep. I don't even think it may have been 2 or 3 times. We did have to get up and down a good bit, but I still always got the most sleep of about anybody. So I was really fortunate. So what does it actually do to us to go without sleep? And has anybody here ever had to go all night or 2 or 3 nights without sleep ever in a row? Yeah. And you know how you feel the next day. You can feel really badly. So it impairs perception. Yes, absolutely. We have difficulty keeping our concentration. We have visual disturbances. So we have slower reaction time. We actually, and this was kind of interesting to me, we have micro episodes of sleep while we're awake. And we don't even know it. We will not even know it. So, yeah, I don't actually know. It could be, because I don't think your eyes actually close. Yes. Yep. And be kind of asleep. And yeah. Yes. And it may be similar to when you're driving, and but you notice that. This is something you don't even notice. And it actually may not be that your eyes even close. We may not even recognize it when we're doing it. And we may not be able to tell when we're looking at somebody that they're doing it. It may be our brain kind of doing, these episodes. And it actually leads to decreased capabilities, efficiency, errors, increased errors, poor memorizing, and what they call schematic thinking, which is organized thinking. So we organize things in our brain to make sense of the world. And it actually decreases the ability to do that. So other things that it does is emotional disturbances. And you may know if your kids or your husband or somebody has not slept well, they're snappy and, so it's deteriorated interpersonal responses, if you want to use a big long term for it.
I like that.
Yeah, isn't that great? Deteriorated interpersonal responses. Otherwise, just being snappy. It's the easy way. Increase aggressiveness. So, and what happens is our brain tissue is actually in a hypermetabolic state. It's actually kind of sped up. And the thalamus, the prefrontal, the frontal, and occipital cortexes are affected, as well as speech centers, which you just mentioned. You can't even speak correctly.
I dressed the whole room of engineers, and when I finished, they went, "Oh."
So what it does is it actually intensifies our muscle tone. If you have a tendency towards tremors, like older people, it will increase those tremors. Your speech can be monotone and unclear. And this is a really big one, especially for us as practitioners. It can really increase pain sensitivity. So, and that's big for everybody because you hurt more when you don't sleep. And that's actually an indication or indicative of fibromyalgia, because people a lot of times are not sleeping well and they may not even know it. They don't make serotonin. They make too much substance P, and that was mentioned in another talk. Substance P causes increased pain. Serotonin lowers pain. So, and those are things that happen when we sleep, or don't sleep, I should say. It changes our immune system and our hormones, especially growth hormone. It increases risk of obesity, diabetes, and coronary artery disease. If you go 20 to 25 hours of sleeplessness, it compares to being over the limit of intoxication when you're driving. It actually compares to 0.1, and now the limit is 0.8. So literally, that's what it can do. And I know I had my first set of twins in my family, but also my first great grandchildren on March 8th. Yes. So, and I went down to help when they were 3 weeks. They were at 33 weeks, so they were early. But they came home on 2 different days, and my daughter works a lot, and my granddaughter had them, and it's kind of a long story. But anyway, I went down to help, stay up all night with them. So I did that for 10 days, or 8 or 9 days for sure. And when I was coming home, it's 5 hours from South Alabama to my house. I kept trying to nod off. I did about 8 or 9 times. So my daughter's in Montgomery, another daughter. I have 3. And I said, get me a big cup of coffee, strong. And I had to go pick something up at her house. And so I was fine the rest of the way home as long as I drank that stimulating coffee. But literally I had to say, I called her, said, talk to me, because I feel like I'm going to go to sleep. And it's the monotony of the road coming to your face and all that. So, and you guys may have been in that situation before. So I believe that it could be, you really can lose impairment when you're not sleeping. So chronic sleep loss accumulates, and it resembles acute sleep deprivation that can last for many, many hours. So some effects on hormones. This is an effect that they did with college kids. When we talk about hormones, they kept college kids up, and they measured their insulin before and after they did this. And their insulin went up significantly when they were kept awake. So when you're not sleeping, and you guys may not know this, but as a doctor, I teach this. The cause of weight gain is not calories. It can be, but it really isn't over time. It is insulin. Insulin causes weight gain. So that's why we can become obese if we don't, or gain weight if we don't sleep well. And it can increase our risk of insulin resistance because we have too much around. So it can be a cascading factor in our hormones. And in a minute, we're going to talk about how all the hormones affect each other, which you may understand that. You know, most people are kind of getting the idea. We have over 200 hormones in our body. Not every hormone affects every other hormone, but there's big groups of hormones like insulin, cortisol, thyroid hormone, and things, sex hormones, that all really affect each other. So there may be smaller hormones that don't affect insulin. There may be, you know, but hormones are a big deal. So it increased their insulin. It increased their insulin resistance, and it caused weight gain, and it increased their risk of diabetes. So this was written up in the International Journal of Occupational Medicine in 2010. And just so you know, total sleep deprivation is not compatible with life. We cannot do it. We will die. So some way or another, you know, we will get sick and die if we do not sleep. So they did some studies on, or they looked at the Americans who sleep less than 7 hours. In 1960, it went from 2% in 1960 to 2011 to 35%. That's really a huge gain. People used to sleep a whole lot better. So we're really struggling across the board as the human race with sleep. Even younger people and kids and babies and so forth are struggling with sleep. So
What was the first date you referenced?
the first
The first date?
1960. Yep. So about 2% of people struggle with sleep, and now it's 35%. So, okay, so we're going to jump over to stages of sleep. So you can kind of get an idea of types of sleep issues, but based on stages of sleep. So we have non-REM sleep, and REM, R-E-M, means rapid eye movement. So it's just a stage of sleep, a type of sleep, and it's what our eyes are doing while we're sleeping, and that's how they come up with these. And it's 75% of our night. And then we have REM sleep, which is about 25% of our night, okay? There's 4 stages of non-REM sleep, stage 1, 2, 3, and 4. So stage 1 is really light sleep. Stage 2 is going to be sleep onset, when you're actually, boom, you're gone. Your temperature decreases. And I didn't know this in medical school, but our temperature actually goes down as we're going to sleep, and it helps us go to sleep. And then when it starts to rise, it wakes us up. And I'm not sure if our temperature rises in hot flashes, but that may be why we have hot flashes, because I will suddenly wake up and I'm not in a hot flash. But within 10 seconds, a hot flash starts. I can feel it rise up in my body after I wake up. Yeah. And you can be really wet. I'm not sure if our internal temperature is going up at that time. I need to investigate that. But temperature is a big deal. So that's why people with thyroid issues can have problems, because that helps regulate our temperature. So that's sleep stage 2, and then 3 and 4 are deepest sleeps, and it's the most restorative part of our sleep. So our blood pressure goes down, our muscles relax, our tissues repair in this time, and this is when growth hormone is released. So this is where growth hormone comes in, and it's really, really important in stage 3 and 4. Okay? So, and we're not dreaming at that time. We're not dreaming in that really deep sleep. So the REM sleep is the other 25% of our sleep, and it occurs about every 90 minutes, all through the night. Now, REM sleep is where we have dreams, but this is also where our brain is really active. So in non-REM sleep, our brain is much more relaxed, but in REM sleep, it's really active. So it's probably doing, you know, our brain takes care of all the daily, what we've learned during the day, memory, doing all those things, probably when it's most active during REM sleep. So our eyes dart back and forth, so they can actually see when you're in REM sleep when they do a sleep study on you. And then your body is immobile during this time. So you're really, really still, very, very still. So those are the types of sleep that we have during the night. And we really want to go through all these stages correctly to get the best benefits of sleep. So in an adult National Sleep Foundation survey, women were more likely than men to have sleep problems. It wasn't a huge percentage difference, but it was 63 to 54% on the men's side, 63% of us. So, so we tend to wake up a little bit more easily, and we tend to have more sleep problems. 15% of the workforce does not have a 9 to 5 job. So there's a lot of folks who do second and third shift, and that can really disrupt sleep because it's harder to sleep in the daytime. And as we get older, our sleep changes and it becomes more fragile. So, you know, older people wake up way more easily. Noises bother them. Different things bother them. Being uncomfortable, you know, all kinds of different things can bother older people as they sleep. So, so some of the hormones we're going to talk about. One thing is cortisol. So during the night, we actually have a diurnal variation. And so this diurnal variation is your hormones, your cortisol drops to the very lowest level at about 3 to 5 a.m. It depends on the person. You know, generally around 4. So if you have a diabetic, they will wake up sometimes with very low blood sugar at 3 or 4 a.m. and they'll start sweating because their cortisol goes low. And when their cortisol goes low, their blood sugar also drops because the higher cortisol is, the higher your blood sugar is. So this is a natural process. It's supposed to happen like this, but no, for diabetics, of course, who are taking medicines or insulin, it can go too low at that time of the morning. So we have to warn people of that. And it'll wake them up. And they'll be sweating and they'll be, you know, shaking and they have to eat. So, but then it starts to go up again, and it even goes up before you wake up. So as your cortisol goes up, your temperature also goes up. And then your cortisol continues to rise and rise and rise, and then it'll peak, I think, I don't know exactly what time, maybe 11 in the morning or so, maybe 12. And then it'll start to go back down again in the afternoon, but it doesn't go as low as in the morning at 3 or 5 a.m. And then it goes back up again in the evening, and then it'll slump back down into the morning. So it kind of, you know, has a couple of humps in it. So this is a natural thing that we're supposed to do. And this helps us sleep and be awake, and sleep and be awake, and lots of other processes that go on with cortisol. So other things that happen during the night if we're not sleeping is, so there's a hormone, the fat storage, feeding, hunger, and fullness. There's several hormones that do this, and one is ghrelin. And I always remember ghrelin because it makes your stomach growl. So ghrelin, that's how I remembered it in medical school. Ghrelin makes your stomach growl, so you'll feel hungry. Okay, and when you don't get enough sleep, your ghrelin goes up, so you feel more hungry. Leptin is another hormone that helps make you feel satiated or full, and it actually goes down. So we don't have as much leptin as we're supposed to when you're not sleeping well. And then insulin, as we've already talked about, goes up. So there are two hormones, ghrelin, yeah, it promotes sleep, and then orexin promotes wakefulness. So those probably come as well in, you know, an orientation with maybe based on cortisol and other things that make us stay awake and go to sleep.
How do you spell it?
Orexin. So, yep.
On leptin, you said that is satiety? Or
Leptin is, yes, it helps us.
Satiety.
Yeah, and there's another one, and I was trying to remember the name of it. There's another hormone that also helps satiety.
yes.
But leptin also may help with fat cells and releasing and letting go of fat or keep holding fat. So, but that also has to do with whether we want to eat more. It's kind of maybe not satiety as much as our drive to eat. So I can't remember exactly each mechanism, but there's several hormones, just so you know, that yes, that have those actions in our body.
To satiety
Yes.
lack of drive.
And those are affected by our sleep. That's the main thing I want you to understand out of those, exactly. All right. So I know that's some physiology and some medical terminology and things like that. Now the second stage I want to talk about, or step I want to talk about, is sleep meds. The sleep meds that I prescribe to people as a physician. So I have several things that we can do. As of course, a lot of people understand that medicines have side effects. But so do herbs. So everything has side effects. Anything we put in our mouth that isn't natural to our body. But some things have less side effects than others. And these are the things I have to make decisions about every day when somebody comes to me. So we have some really stronger sleep medicines like Ambien and Lunesta and benzodiazepines. And benzodiazepines are anxiolytics. So that's things like you may have heard of Klonopin, you may have heard of Ativan, Xanax, Valium, several of these types of medications. There's other medications that we do. There's one called Belsamra, and that is a medicine that even the elderly are supposed to be able to take. And then we have a lot of antidepressants are actually make people sleepy. So we have one called Trazodone. We have another one called Remron. We also often give to the elderly who are too thin because it also causes weight gain. Some of the antidepressants cause weight gain. So there's several of these antidepressants that we can also use that make people sleepy. Other over-the-counter medicines that people will often get are Benadryl. And that's going to be in medicines like Tylenol PM or Advil PM. I know that's kind of loud, isn't it? It's probably going to pick up by the microphone, but they're blending something or doing something in the kitchen, and we can't block it, so that's okay. This is practice anyway, and I may try again tomorrow. So, so these are decisions, and I have people coming to me that take tons of Benadryl. One of the problems with Benadryl is it can cause memory problems. And it can do it in young people. If you take it every single night to help you sleep, you can lose your memory and you can have issues.
Yeah.
Yes. Now, fortunately, most of the time you can get it back if you're young enough. But as you get older, it may actually keep you, you may struggle to get those memories back. So I tell people, the older you get, do not use Benadryl. Do not use. And I have a lot of people, they'll take 2, 4, 6 Benadryls. The other problem with that is they're taking too much Tylenol or ibuprofen as well, because ibuprofen is mixed with Benadryl, and those can be really harmful to the body. You can take plain Benadryl as well. And there have been many doctors in the past, I don't think they do it anymore, who told parents, give your kids Benadryl if you can't get them to sleep. Even when they were really small. And that's like, whew, we don't do that anymore, or I don't for sure. So
Is Benadryl unique in that it causes memory problems, or is that a situation with a lot of these sleep drugs?
Benadryl is not unique in causing memory problems. There are lots of medications that do.
Sleep ones?
So
Well, this
Yes,
not
yes. So the issues between, like Ambien causes more vivid dreams, nightmares, walking in your sleep. I'm not aware of it causing memory issues, but we feel that Lunesta and Ambien may contribute to dementia. So that's a big deal. Yes. So which may be memory issue if you want to think about that in the long term. It may not do it short term, but it may do it in the long term. So yes, I think those can contribute to dementia. I'm not exactly sure the mechanism on those, like can it put more tau plaques in your, amyloid plaques and tau in your brain. I'm not aware of it doing that. I think other mechanisms are, but we don't really know, I think, totally the mechanisms that some of these medicines lead to dementia. So that's a really big reason I hate to prescribe it for anybody long term. And you can become dependent on it and not be able to go to sleep without it.
Are there any studies talking about how deep sleep we get into if they're on Ambien?
There
Like,
probably
do you still
are.
get into that deep sleep stage, the 3 and 4?
There
to the same
probably
extent?
there probably are studies about that. I don't know I don't know the literature. I'd have to look it up.
Because if that's the restorative time, I wonder if it keeps us out of deep sleep.
Well, that's kind of the problem with sleep meds in general. Yes, you don't get that restorative. So it definitely affects REM sleep, and which is where your brain, learns and stores things. So I don't know all the data and the literature on it, but it definitely is going to have an effect. And that's another reason that we don't want people to use these medications. Another problem with them is sometimes the dose to get you to sleep keeps you groggy the next day. And we find that there's a really fine line between getting to sleep and then being groggy. So, so this is just a little tiny primer on why sleep medications can be harmful to us and why we really want to sleep properly without them if we can do it. But it's also a reason that I have worked towards using herbs, because some herbs don't do some of these quite, these harmful things as sleep meds can in some people. And the other thing is some of these just don't work. And I feel like I need other tools that are readily available to people, over the counter and things like that aren't as harmful as Benadryl. So, all right. So the next area.
Before we get off of sleep.
Yes.
Totally.
Questions. No problem.
Sorry. So, like a lot of people will take Benadryl. I'm a coach. I work with a lot of people, and it's fitness, so it's like all stages of life. Where sleep is usually the first thing that I look at.
Right.
And so I have a lot of people that take melatonin.
Yes. And we're going to talk about melatonin.
Okay. Cool.
Yeah.
Never mind.
Because I have supplements and herbs
Perfect.
coming up.
Perfect.
So I'm just trying to get you
awesome.
get everything. No problem. No problem. So some medical causes of sleep issues can be low iron, low B12, of course thyroid issues, which we've already mentioned, and your hormones are out of balance. So, and we see now calling hormones out of balance in women who are going through menopause, I'm not so sure that's correct, because that's what we naturally do. So I don't know if that's out of balance. It's just different. But I do know that there are people in other countries, in other cultures, I should say cultures, not necessarily countries, less westernized and so forth, who don't have menopause issues like we do. So I really want to study more on that and see why, but they feel like it's native food, that they're eating native foods. And
that's stress.
exactly. So we do have hormone, the camera doesn't hear this, but you said hormone disruptors, and absolutely. And the other thing is carbohydrates. We eat a lot of carbohydrates, which may cause, I know for me, it causes me to have more hot flashes. So
And see, I'm the opposite. If I'm too low on carbohydrates, and that nutrition I'm very much dialed into, and if I'm too low on carbohydrates, then it sends me off of crazy cycles, and I feel terrible.
Right, but that may not be hot flashes. You're not
No,
old enough to have hot flashes.
No,
right.
not hot flashes.
Right.
But at the point in life where I am in my cycles and my hormone cycles,
yes.
And so that is different for other people too.
Yes.
So it could be too much or too little. It's not necessarily.
So right, and I'm not arguing with that in your case. And women, there's lots of hormone issues in women that are different from men. Especially in intermittent fasting and things like that. So we're learning more about fasting, but we'll have that on another. I do a talk on fasting as well, but not. Yes, and that's why I'm saying the hormones can be out of balance, but they may not be out. If they are out of balance, yes, you may have more hot flashes. So, but it's normal for us to change our hormones to change. So I was kind of trying to make that point, but absolutely. So stress, cortisol, all of it, like I said, all these hormones work together. So that's a major cause of sleep issues. And that can even be in men as well. So they can have low testosterone and different things, and it gets everything out of balance. So, all right. So the way we evaluate sleep, we don't have a good way as a physician to evaluate sleep. We do sleep studies for obstructive sleep apnea. So, and now they even let you do those at home. But there are tests, and I've never sent anybody for a sleep test where they look at their rapid eye movement sleep and watch them sleep to see what their problems are. We only do obstructive sleep apnea. I'm not even sure where to send somebody to get any other kind of sleep study, and I'm not even sure insurance would even pay for it to be able to do it. So that can be difficult. Yes, there are, and you can wear things on your wrist and stuff like that, but I'm not sure how accurate they are. When they do these sleep studies in a lab, they put electrodes on your head. They do EKGs. They hook you up to. It would. I agree. It would be hard to sleep with all that on you. But you'd be surprised though. You can still get information from it. Yes. Right. And you can still get information. I mean, we use tools for people's hearts to see if they have heart palpitations through the night, low oxygen, all these different things. And people do sleep, even with the tools on. So, it's never perfect, but you definitely can get some information. But just to let you know, as a physician, I don't have anywhere to send anybody that I'm aware of. I probably could study up on it. There may be something in Birmingham. There may be something in Atlanta.
I would even argue the point of like with the rings. No, it's not perfect, but it's something.
Right.
Like that might
Exactly.
be a good accessible place to start on that.
Yes, and how many times, and yes, absolutely.
So when you went to the neurologist, they do sleep and then studied that.
Yes.
In a way, maybe a neurologist would be good. But of course,
Yes.
probably do that.
And we send folks to neurology, but even my local neurologists have never sent anybody for a real, they just say, oh, just go home and do this. They don't really study how people are sleeping, like 35% of people aren't sleeping as well as they should, and we are not doing 35% of studies on people who are having sleep issues.
Sleep spec scans a thing?
I'm not sure. Well, that's kind of what this is. It's not a spec scan because you have to be in a piece of equipment, to do that. So they may do it as experiments in a lab, but not on a regular basis. So anyway, so it's just not easy to determine. A person might not know what their sleep problem is without being able to do some of this, but they just know they don't feel good or they're not sleeping as well as they should. So there's two things to think about with sleep. Do you have a hard time going to sleep, or do you wake up often during the night? So those are the two things that most people tell us. Okay, well, I can't get to sleep. My brain won't stop. My brain won't shut up, that kind of thing. So the tools I have, anybody have any more questions on that?
Is there a difference between retrieval if you wake up or
There is. Yep. And even the herbs. There's different herbs that do different things. And we'll talk about that when we get into the different possibilities. So typically when I give a medication for sleep, it doesn't differentiate. You just take it before bedtime and it zonks you out. So there isn't this, there's no fine tuning as much. And there may be with other substances.